Recording in progress.
Good morning, myself Dr. Mullai Ganesh from Chettinad Hospital and Research Institute, Kelambakam. Today we are going to see the topic Unveiling the Intricacies, Exploring Brain Vascular Malformations through MR Imaging. Most CVMs are congenital lesions and represent morphogenetic errors affecting the arteries, capillaries, veins, or a combination of them. Development of the human fetal vascular system occurs via two related processes, vasculogenesis and angiogenesis. In vasculogenesis, capillary-like tubes develop first and constitute the primary vascular plexus. This is subsequently remodeled into large caliber vessels such as arteries, veins, and small capillaries. Angiogenesis is regulated by a number of intercell signaling and growth factors. Mutations in various components of this system have been implicated in the development of various CVMs. Histopathologically, CVMs could be classified into AVMs, venous angiomas, capillary telangiectasia, and cavernous malformations. We aim to describe the MRI findings of various brain vascular malformations to aid in the diagnosis and planning of the management. Retrospective evaluation of MRI features in 10 patients with various brain vascular malformations was done in our department over a course of 1 year. The first case was a case of arteriovenous malformation. It was a case of 59-year-old male who presented with complaints of headache. On T2 and FLAR sequences, we were able to see multiple flow voids in the left parieto-occipital region with a nidus seen containing gliotic brain parenchyma. GRE sequences showed blooming, and angiogram sequences showed branches of the PCA communicating with the nidus. Post-contrast, we saw a nidus in the parieto-occipital region with shunting between the branches of PCA and cortical veins. It was graded as Special Martin, grade 2. AVMs are the most common vascular malformations of the brain, and a direct shunt between the artery and a vein with multiple thin vessels called a nidus connecting the two without any evidence of a capillary bed. The hallmark imaging feature is the bag of worms appearance. On MR, we can appreciate tightly packed mass of honeycomb of flow voids on T1 and T2 as they are high flow lesions. Brain parenchyma appears gliotic and is hyperintense on T2 and FLAR images. GRE sequences show blooming, and MR angiography shows dilated and tortuous feeding arteries with tightly packed angle of abnormal arteries and veins with no intervening capillary bed or brain parenchyma. Our second case was a case of a 54-year-old maid who presented with complaints of headache and giddiness, and imaging showed an area of altered signal intensity in the left occipital lobe with multiple flow voids noted on T2 and FLAR sequences. GRE sequences showed blooming, and MR venogram showed numerous and extensive prominent and tortuous dural varicosities predominantly near the left transverse sinus. This was a case of a dural AV fistula, which is the second most common CVM with AV shunting. These are tiny crack-like vessels that shunt blood between the meningeal arteries and small venules within dural sinus wall. They occur usually in the transverse sinus in the case of adults and superior sagittal sinus in the case of children. MR imaging features include dilated cortical veins without nidus adjacent to normal appearing brain parenchyma. A thrombus dural venous sinus with flow voids is the most common finding, and the thrombus may appear T1 and T2 isointense and typically shows blooming. Angiography is the best tool. DSA with super selective catheterization of dural and transosseous feeders are required. Dural branches may arise from the ECA, ICA, and vertebral arteries. Presence of dural sinus thrombosis, flow reversal with drainage into cortical veins and engorged tortuous pial veins is characteristic. Our next case was a case of a 37-year-old female. On imaging showed asymmetrically dilated and tortuous left superior ophthalmic vein and dilated left half of the cavernous sinus. A large partly thrombosed aneurysm was noted in the cavernous segment of left ICA, with high communication between the intercavernous portion of the left ICA and left cavernous sinus also noted. This was a carotido-cavernous fistula, Barrow type A. Carotido-cavernous fistulas are AV shunting developing within the cavernous sinus and can be classified as either direct, which is a high flow type, and indirect, which is a slow flow, low pressure type. Imaging features include a bulging superior ophthalmic vein and cavernous sinus on T1 sequences with asymmetric flow related signal loss seen on T2. Angiography features for direct CCFs include rapid flow with early opacification of the cavernous sinus, whereas for the indirect type, multiple dural feeders from the cavernous branch of the ICA and deep branch of the ECA are seen, with anastomosis between the ICA and ECA feeders being common. Our next case was a case of a 40-year-old female who presented with complaints of giddiness and imbalance while walking. Imaging showed T1 iso-intense areas and T2/flare hyper-intense areas with no associated diffusion restriction with blooming on SWY sequences. Post-contrast study showed subtle enhancement with medusa head appearance of prominent medullary veins converging in the transcortical collector vein. This was a developmental anomaly with hemosiderin deposition. Developmental venous anomalies are umbrella-shaped CVMs with mature venous part with no arterial component, mostly seen as small-sized solid lesions commonly found near the frontal horn of lateral ventricle. Imaging features usually appear normal on T1 but show post-contrast delayed collection of linear enhancing structures joining subependymal collector veins. MRA is usually normal, whereas MRV gives a characteristic medusa head drainage pattern. Our next case was a case of a cerebral cavernous malformation, which shows on imaging showed an area of altered signal intensity appearing heterogeneously hyperintense on T1, hypointense on T2 and flare, and showed blooming on gradient sequences with corresponding hyperintensity on phase sequences, predominantly in the right precentral gyrus with fluid level and hypointense rim. This was a case of a cavernous hemangioma with hemorrhage with the blood being in the subacute to chronic stage. So it's classified as Zabramsky type 2. Cerebral cavernous malformations are characterized by intralesional hemorrhages into thin-walled, angiogenically immature blood filled. Imaging characteristics include a characteristic focal central heterogeneity or popcorn appearance on T2 with circumferential hypointense ring of hemosiderin formed around the high-intensity central areas. This is the summary of the cases that we have seen, with the results and conclusion of the study as follows. Thank you.